Intubation of burn patients with inhalation injury. Expanded lecture note. Intubation of burn patients with inhalation injury, a critical approach. Intubating burn patients with suspected inhalation injury is a high-risk procedure that requires careful consideration and planning. These patients often present with complex airway management challenges, including edema, inflammation, and potential airway compromise. Effective airway management is crucial to ensure adequate oxygenation, ventilation, and prevention of further complications. By understanding the unique challenges and considerations involved in intubating burn patients with inhalation injury, healthcare providers can optimize patient outcomes and reduce the risk of complications. Learning objectives. By the end of this lecture, the trainee will be able to 1. Explain the pathophysiology of inhalation injury and airway edema after burns. 2. Recognize clinical and investigational indications for early intubation. 3. Choose appropriate airway techniques and drugs for burn patients. 4. Manage ventilation, monitoring, and complications after intubation. 5. Know when to convert to a surgical airway and when to consult burn ENT teams. These learning objectives will guide our discussion on intubation of patients with inhalation injury. Definition and scope of inhalation injury. 1. Inhalation injury. Respiratory tract damage. Inhalation injury refers to damage to the respiratory tract and lungs caused by heat, smoke, and chemical irritants. Fire and smoke exposure. This type of injury is during exposure to fire or smoke, and can have serious consequences for the patient. 2. Types of inhalation injury. Thermal injury. Thermal injury typically affects the upper airway, above the vocal cords, and is caused by heat. 3. Chemical smoke injury. Chemical and smoke injury can affect the lower airways and lung parenchyma, caused by toxic gases and particles. 4. Asphyxia. Systemic toxicity. Inhalation of toxic substances like carbon monoxide, CO, or cyanide can lead to asphyxia or systemic toxicity. Inhalation injury can have a significant impact on patient outcomes, and early recognition and management are critical to ensuring optimal care. Why airway management is critical in inhalation injury. 1. Thermal injury and edema. Rapid progressive edema. Thermal injury causes mucosal inflammation, leading to rapid progressive edema of the oropharynx and larynx. Airway obstruction risk. Edema can appear within hours and progress over 12 to 24 hours, risking complete airway obstruction. 2. Smoke and particle inhalation. Airway damage. Smoke and particle inhalation trigger airway mucosal sloughing, bronchospasm, and impaired mucociliary clearance. Inflammatory lung injury. This can lead to inflammatory lung injury and acute respiratory distress syndrome, ARDS, increasing oxygenation and ventilation needs. 3. CO and cyanide exposure. Tissue hypoxia. CO and cyanide exposures produce tissue hypoxia despite normal SpO2 readings. Specific treatment. High FiO2 and specific antidotes, such as hydroxycobalamin for cyanide poisoning, may be required to manage these patients. Effective airway management is crucial in patients with inhalation injury to prevent airway obstruction, ensure adequate oxygenation and ventilation, and manage potential complications. Assessment of inhalation injury. Who's at risk and what to look for. 1. Important history. Enclosed space fire. Patients who have been in an enclosed space fire are at higher risk for inhalation injury. Prolonged exposure. Prolonged exposure to smoke and heat increases the risk of inhalation injury. Loss of consciousness. Loss of consciousness during the fire or exposure is a concerning sign. Burns to face, neck. Burns to the face and neck area increase the risk of inhalation injury. 2. Key exam findings. Facial burns. Facial burns are a sign of potential inhalation injury. Singed nasal oral hair. Singed nasal or oral hair suggests exposure to heat. Soot in mouth, nares. Soot in the mouth or nares is a sign of inhalation of smoke. Hoarseness, voice change. Hoarseness or voice change may indicate a injury. Stridor. Stridor is a concerning sign of airway obstruction. Progressive dyspnea. Progressive difficulty breathing is a sign of potential airway compromise. Cough with carbonaceous sputum. Coughing up carbonaceous sputum suggests inhalation of smoke. 3. Adjuncts, diagnostics. Direct laryngoscopy, flexible bronchoscopy. These procedures can help visualize airway mucosa and grade inhalation injury. Carboxyhemoglobin (CoHB) level. CoHB level can help diagnose carbon monoxide poisoning. Arterial blood gas. Arterial blood gas can help assess oxygenation and ventilation. Chest X-ray. Chest X-ray may be normal early in inhalation injury. Pulse oximetry. Pulse oximetry can be misleading in carbon monoxide poisoning. Early recognition of inhalation injury is critical to ensuring optimal patient outcomes. A thorough assessment and evaluation are essential to identify patients at risk and guide management. Indications for intubation, practical mnemonics and criteria. There is a low threshold for early intubation in suspected inhalation injury. 2 commonly used clinical tools. Fire-safe mnemonic for bedside memory. F. Facial burns. Burns around the mouth, nose, or face predict rapid swelling that can obstruct the airway. I. Increasing size, progressive swelling. Neck or facial edema progresses quickly and makes late intubation almost impossible. R. Respiratory distress, failure, hypoxia, hypercapnia, tania, low oxygen saturation, or rising CO means the patient is tiring and needs ventilatory support. E. Extensive burns, head, neck, chest. Large burns in these regions restrict breathing and signal impending airway compromise. S. Soot or carbonaceous material in airway. Black sputum, singed nasal hairs, or soot in the mouth confirms inhalation injury and hidden airway damage. A. Altered mental status, GCS and LT. 8 patients with low consciousness cannot protect their airway and risk aspiration or obstruction. F. Funny sounds, stridor, hoarseness, wheeze, abnormal upper airway sounds indicate narrowing from swelling or laryngeal injury. E. Early intubation. Acting early is safer because swelling worsens quickly and delays can make intubation impossible. Denver, ABLS, ATLS thresholds. Full thickness facial burns, stridor, progressive hoarseness, visible airway edema, respiratory failure, burns in enclosed space exposures, or inability to protect the airway are strong indications for intubation. Early elective intubation is recommended in these situations to avoid a crash scenario. Important data point. Bronchoscopy and CT imaging can show airway injury such as bronchial wall thickening, and carboxyhemoglobin levels reflect smoke exposure, but these remain supportive goals. Clinical signs are still the strongest triggers for safe and timely intubation. Timing of intubation in inhalation injury, early versus delayed. 1. Early, elective, intubation. Prevents airway loss. Early intubation is favored if risk factors or signs are present, preventing catastrophic loss of airway when edema progresses. Low threshold. Guidelines encourage a low threshold for intubation in at-risk patients. Proactive approach. Early intubation is a proactive approach to managing potential airway compromise. 2. Delayed intubation. Close monitoring required. Delayed intubation may be acceptable if there are no signs of airway compromise and close monitoring is possible. Edema evolution. Edema often evolves over 6 to 24 hours, requiring continuous monitoring and readiness to act. High vigilance. Delayed intubation requires high vigilance and a readiness to intubate if signs of airway compromise develop. The decision to intubate early or delay should be based on careful assessment of the patient's risk factors and clinical signs, with a focus on preventing airway compromise and ensuring optimal patient outcomes. Preparation and team brief before intubation. 1. Assemble experienced team. Airway lead. Assemble a team with an experienced airway lead, assistants, nurse, and respiratory therapist. Surgical backup. Have surgical backup available in case of emergency. 2. Airway kit preparation. Video laryngoscope. Prepare a video laryngoscope for difficult airway management. Flexible fiber optic bronchoscope. Have a flexible fiber optic bronchoscope available for visualization. Boogies and endotracheal tubes. Air boogies and endotracheal tubes of various sizes. Smaller tube size. Burn patients often require smaller tube sizes due to edema. Surgical airway tray. Have a surgical airway tray available for emergency cricothyrotomy or tracheostomy. 3. Preoxygenation and preparation. Preoxygenate with 100% O. Preoxygenate the patient with 100% oxygen to increase oxygen reserves. Gentle suction. Remove particulate debris and soot with gentle suction to clear the airway. High-flow oxygen. Provide high-flow oxygen immediately for suspected inhalation injury. Adequate preparation and team brief are crucial to ensuring a safe and successful intubation in patients with inhalation injury. Technique choices and special drug considerations for intubation. 1. Rapid sequence induction, RSI. Commonly used technique. RSI is commonly used for intubation in burn patients. Induction agent choice. Choose induction agent based on hemodynamics, such as etomidate or ketamine. 2. Neuromuscular blocker, NMB, choice. Succinylcholine may be used within the first 24 to 72 hours after a severe burn, but avoid use later due to risk of hyperkalemia. Alternative NMB. Use rocuronium or uronium instead of succinylcholine when contraindicated. Awake fiber optic intubation. 1. Indications. Cooperative patient. Indicated when the patient is cooperative and has a suspected difficult airway. Difficult airway. Massive facial burns or limited mouth opening can make intubation challenging. Maintaining spontaneous ventilation. Prioritizes maintaining spontaneous ventilation, reducing the risk of respiratory compromise. 2. Requirements. Topicalization. Requires topical anesthesia to numb the airway and reduce discomfort. Expertise. Requires expertise in flexible bronchoscopy and airway management. Benefits. 1. Assessment of injury. Flexible bronchoscopy can be used to assess the extent of airway injury. 2. Controlled intubation. Allows for controlled intubation while maintaining spontaneous ventilation. Awake fiber optic intubation is a valuable technique for managing difficult airways, especially in patients with facial burns or limited mouth opening. Video laryngoscopy. Benefits. 1. Increased first pass success. Often increases first pass success in difficult airways. 2. Recommended as first line. Widely recommended as first line when available due to its effectiveness. Technique. 3. Combination with bougie. Can be combined with a bougie if needed to facilitate endotracheal tube placement. Improved visualization. Provides improved visualization of the airway, making intubation easier. Video laryngoscopy is a valuable tool for managing difficult airways, and its use can improve the success rate of intubation. Surgical airway. 1. Indications. Failed intubation. Be prepared for a surgical airway if intubation fails or is impossible. Impossible intubation. Surgical airway is a life-saving option when other methods are not feasible. 2. Types of surgical airway. 1. Cricothyrotomy, an emergency procedure to establish an airway. 2. Tracheostomy, may be used later, and GT, 48 to 72 hours, to avoid laryngeal injury in prolonged intubation. 3. Benefits of early tracheostomy. 1. Avoids laryngeal injury. Early tracheostomy can help avoid laryngeal injury associated with prolonged intubation. 2. Long-term airway management. Tracheostomy can provide a stable airway for long-term management. Surgical airway management is a critical component of airway management, especially in cases where other methods are not possible or have failed. Post-intubation ventilator strategies and ICU care in burn inhalation injury. 1. Lung protective ventilation means using smaller tidal volumes, 6-8 ml per kilogram ideal body weight, to prevent further lung damage caused by overstretching fragile lung tissues. 2. Keeping plateau pressure below 30 cmHO protects against barotrauma and minimizes ventilator-induced lung injury. Early peak titration helps keep the alveoli open, improve oxygenation, and prevent atelectasis, which is common after inhalation injury. Recruit maneuvers can reopen collapsed lung areas, but they should be used cautiously to avoid hemodynamic compromise. 3. Humidified ventilator circuits prevent drying and crusting of airway secretions, making suctioning and clearance easier. Frequent suctioning is essential because soot and slough cosa can obstruct the airway and worsen gas exchange. Nebulized bronchodilators like beta-2 agonists reduce bronchospasm, improving airflow and oxygen delivery to the injured lungs. 4. Frequent bronchoscopy allows direct visualization of the airway, removal of debris, and monitoring of healing progression. Pulmonary toilet techniques, including chest physiotherapy and postural drainage, support secretion clearance once the patient is stable. Coordinated ICU care with close monitoring, lung protective strategies, and aggressive airway hygiene improves survival and reduces long-term complications. Specific toxicities to address simultaneously. 1. Carbon monoxide, CO, poisoning. Administer 100% O. Provide 100% oxygen immediately to help displace CO from hemoglobin. Hyperbaric oxygen. Consider hyperbaric oxygen for severe CO poisoning, especially with loss of consciousness, neurological deficits, or CoHB more than 25-30%. Pulse oximetry limitations. Pulse oximetry may be falsely normal in CO poisoning. CoHB level. Obtain CoHB level to diagnose CO poisoning. 2. Cyanide toxicity. Suspect in enclosed space fires. Suspect cyanide poisoning in patients with severe smoke inhalation from enclosed space fires. Presents with lactic acidosis. Cyanide toxicity presents with lactic acidosis and refractory shock. Treatment with hydroxycobalamin. Treat with hydroxycobalamin if cyanide poisoning is suspected. Prompt recognition and treatment of these specific toxicities are crucial to ensuring optimal patient outcomes. Simultaneous management of CO and cyanide poisoning can help mitigate the effects of these toxins and improve patient survival. Complications of intubation in burn patients. 1. Airway challenges. Edema-related difficulties. Difficult or failed airway due to edema can occur. 2. Hypoxemia risk. Hypoxemia can develop during intubation attempts. 3. Aspiration risk. Aspiration risk is increased in burn patients. 4. Post-intubation complications. 1. Pneumonia. Post-intubation pneumonia is a common complication. 5. Ventilator-associated lung injury. Ventilator-associated lung injury occur. 6. Prolonged mechanical ventilation. Prolonged mechanical ventilation may be required. 7. Tracheostomy. Tracheostomy may be necessary for long-term airway management. Medication-related complications. 8. Hyperkalemia. Succinylcholine used late after burn injury can cause hyperkalemia. Understanding these potential complications is essential to providing optimal care for burn patients requiring intubation. Early recognition and management of these complications can help improve patient outcomes. When to convert to tracheostomy. 1. Prolonged ventilation. Timing. Consider tracheostomy in patients who require prolonged ventilation, typically in GT, 7-14 days. Benefits. Tracheostomy can reduce laryngeal injury risk and facilitate urinary toilet and weaning. 2. Early evaluation. Multidisciplinary evaluation. If intubated more than 48 to 72 hours for airway protection, evaluate the need for tracheostomy early with ENT and burn teams. Collaborative decision-making. Collaborative decision-making can help determine the optimal timing for tracheostomy. Tracheostomy can be a valuable option for patients requiring prolonged ventilation, and early evaluation and decision-making can help ensure optimal patient outcomes. Monitoring, documentation and communication. 1. Documentation. Rationale for intubation. Document the rationale for intubation. Tube size and position. Record tube size and position, cm at lip. Difficulty grade. Document the difficulty of intubation. Number of attempts. Record the number of attempts made. Devices used. Document the devices used during intubation. Immediate complications. Note any immediate complications. 2. Communication. Multidisciplinary communication. Communicate with the burn unit, ICU, ENT, and surgical teams. Daily reassessment. Reassess the airway daily to plan for potential changes. 3. Ongoing care planning. Planning for tube downsizing. Plan for tube downsizing or tracheostomy if prolonged intubation is anticipated. Collaborative care. Collaborative care and communication can help ensure optimal patient outcomes. Thorough documentation and effective communication are essential to providing high-quality care for patients with inhalation injury. Practical checklist for intubation in burn patients. 1. Rapid primary survey. ABC assessment. Perform a rapid primary survey, assessing airway, breathing, and circulation, ABC. Apply 100% O. Apply 100% oxygen to ensure adequate oxygenation. 2. Assessment and preparation. Fire-safe features. Look for fire-safe features or Denver criteria to assess the need for intubation. 3. Team and equipment preparation. Prepare the team and equipment, including video laryngoscope, bronchoscope, bougie, and surgical airway. 4. Pre-intubation preparation. Pre-oxygenation. Pre-oxygenate the patient to increase oxygen reserves. Suction airway. Suction the airway to clear debris and secretions. 5. Intubation technique. Choose the intubation technique, considering RSI or awake fiber optic intubation. NMB consideration. Consider the timing of neuromuscular blockade, NMB, and avoid succinylcholine after the early window. 6. Post-intubation care. Confirm endotracheal tube placement using ETCO waveform. Secure tube. Secure the tube and obtain a chest X-ray to assess tube depth. 7. Lung protective ventilation. Initiate lung protective ventilation strategies. Specialist consults. Consider bronchoscopy and specialist consults as needed. This practical checklist can help guide healthcare providers in managing the airway of burn patients, ensuring a systematic and effective approach to intubation and post-intubation care. Teaching cases and exam-style questions. 1. Case 1. Intubation decision. Patient presentation. A patient with facial burns, hoarseness, and singed nasal hair from an enclosed space house fire. Intubation decision. Yes, early elective intubation is indicated due to the risk of progressive airway edema. Rationale. The presence of soot in the oropharynx and signs of potential airway compromise necessitate proactive airway management. 2. Case 2. Succinylcholine use. Patient scenario. 8 24-hour post-patient needing surgery with full-thickness burns but no airway symptoms. Succinylcholine safety. No, succinylcholine is contraindicated after the early period, often more than 24-48-72 hours, due to the risk of hyperkalemia. Alternative. Use a non-depolarizing neuromuscular blocking agent, NMBA, instead to avoid potential complications. These cases highlight key considerations in managing burn patients, including the importance of early intubation and careful selection of neuromuscular blocking agents. Pearls and pitfalls in burn patient management. 1. Pearl. Early elective intubation. Indications. Err on the side of early elective intubation when facial burns or enclosed space exposure plus airway signs exist. Rationale. Late attempts can be impossible due to progressive airway edema. Importance. Early intubation can prevent catastrophic airway loss. 2. Pitfall. Pulse oximetry limitations. CO poisoning diagnosis. Don't rely solely on pulse oximetry to rule out CO poisoning. CoHB measurement. Get CoHB levels to diagnose CO poisoning accurately. Prompt treatment. Treat with 100% O promptly to mitigate CO poisoning effects. 3. Pearl. Surgical airway preparedness. Equipment readiness. Have surgical airway equipment ready in case failed intubation. Team preparedness. Team preparedness reduces catastrophic outcomes and ensures optimal patient care. Importance. Being prepared for surgical airway management can save lives in emergency situations. By understanding these pearls and pitfalls, healthcare providers can improve their management of burn patients and reduce the risk of complications. Suggested references for learners. Thank you for watching. If you liked this content, don't forget to like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.